Good evening and welcome to Doctors on Call. What would you like to know about testicular and prostate issues like erectile dysfunction, incontinence, and prostate cancer? I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm your host for tonight's program on men's health. We'll be happy to answer your questions. Just give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome our panelists this evening, Dr. Nicholas Johnson, a urologist with St. Luke's Urology Associates in Duluth, Dr. Ryan Novak, a urologist with Grand Itasca Clinic and Hospital in Grand Rapids, and Dr. Erik Sather, a family medicine physician with Essentia Health-Lakeside Clinic in Duluth. Our medical students answering phones tonight are Alicia Colling from Scandia, Minnesota, Sarah Geller of Mankato, Minnesota, and Aaron Mustonen from Little Falls, Minnesota. And now on to tonight's program on men's health. So while we're waiting for some questions, we'll have a little bit of a discussion on some different topics. So Dr. Sather, I think we'll start with you and just ask, when should a man come to be seen as a physical or for an evaluation at a physician's office?
Well, anytime's a good time if you have any symptoms that you want to discuss. But for general physicals, there's a lot of screening that starts at around age 40 for certain conditions like diabetes and high cholesterol. And at age 50, there's a couple of cancer screenings that come up, like colon cancer screening, prostate cancer screening, and a few vaccines that we start to discuss at that age as well. But anytime, again, if you have risk factors too for some of those conditions, like if you're obese and have risk factors for diabetes, high cholesterol, high blood pressure, to get those things checked out and get a yearly screening or physical at that point.
That's really helpful. So PSA is probably one of the common things we hear about. Dr. Johnson, can you talk about PSA? What am I talking about when I say PSA?
Sure. PSA stands for prostatic specific antigen, and it was first introduced in the early 1990s as a screening test for prostate cancer. Really good data that shows a correlation between the PSA number and the existence of prostate cancer. It has become a very hot topic over the last couple of years, and how to use PSA and use it specifically for prostate cancer screening is under a lot of debate and something we could probably talk more about tonight. But the one thing I'll say now is it is still the best screening test, the single screening test that we have to detect prostate cancer, and if used smartly, is a very important tool in prostate cancer detection.
So if a patient had an elevated PSA, Dr. Novak, what would be the process that the patient would go through?
Well, the first thing would be just a discussion. Important factors such as the patient's age, their family history, their race. All those are important factors in determining exactly what to do. There's no magic number that you can give specifically that applies to everybody. It's a very individual decision that requires a conversation in terms of the risks and benefits of proceeding with a possible biopsy versus observing the PSA versus repeating it at a certain interval.
Would there be symptoms for prostate cancer that a man should look for, Dr. Sather?
Well, there might be some, but it depends on how advanced the cancer is. Often you might get complaints of having trouble urinating or a weak stream or having to strain harder to go, having to go more often because you can't empty the bladder completely, often waking up at night several times to go during the night, and if that's getting worse, you might want to get that checked out. There are other conditions that can cause those symptoms. Again, the probably more common would be an enlarging prostate as a guy gets older, benign prostatic hypertrophy. Also, sometimes infections or inflammation called prostatitis can cause some of those similar symptoms. So it's important that you get, if you're having those symptoms, you get that checked out so we can discuss all the possibility of what could this be, how to go out assessing those things. Like, would we get a blood test like a PSA or some other tests, or do an exam like a rectal exam and feel the prostate to see if you might have any one of those conditions that might cause some of those symptoms, and then figure out what's the best way to treat that or to refer on if we're concerned about a condition like prostate cancer.
Mm-hmm.
I just add to that, I think that's a great response, and the important point though is that prostate cancer in most men usually does not have symptoms, and so that's where the PSA screening has become so valuable. That's the most common way to pick up prostate cancer is with a blood test, a screening test. And as was just talked about, the symptoms usually have nothing to do with prostate cancer, are usually a benign process. Prostate cancer needs to be ruled out and working that up, but the important part is if you're having symptoms, to get it checked out, and if you're not having symptoms, to still keep prostate cancer screening in mind, because usually it presents without any symptoms at all.
So, Dr. Novak, if we were doing a workup, we'll just stay on prostate cancer for just a little bit longer. You talked about doing a biopsy. How is that done?
Well, everybody, different urologists can perform it different ways, but it's typically an ultrasound guided biopsy so that you can visualize the prostate, which is the target, through an ultrasound probe that's placed in the rectum. It can be performed in the clinic most commonly. Occasionally it can be performed in the operating room if need be. Ideally, though, and most men tolerate it quite well in the clinic setting. The process takes about 5 or 10 minutes. The ultrasound is used to guide the needle, and the number of cores or tissue samples is a little bit, again, dependent on the urologist, but it's typically somewhere around 8 to 12 samples that are taken. Those samples are then sent to the pathology lab, and depending on the hospital, it can take anywhere from a couple days to a week or so to get the results.
Excellent. Dr. Sather, a caller from Duluth, one of the complaints often is getting up in the middle of the night to urinate more frequently. So maybe a little bit about that, but then they're also asking if there's any medications that can be used for that.
Yeah, it kind of depends on how much of a bother it is, and again, what the cause is. But again, most commonly, what I see with that symptom is going to be an enlarging prostate. Again, that benign prostatic hypertrophy, or sometimes we'll call it BPH. There are certain, again, if it's a bother to you, if it's affecting your sleep or anything like that, there are some medications that can be prescribed. So certain medications are called alpha blockers. Prostate's kind of a mix of gland tissue and muscle tissue, and those alpha blockers tend to relax the muscle to allow the urine to flow better. There are other medications that help shrink the prostate, and deciding which medicine is right for you, or if any medicine at all is right for you. Again, we talk about what the benefits of the medication are, what the risks are, because those medications have risks. The alpha blockers can lower blood pressure, make people lightheaded when they stand up. And again, there might be other symptoms with the other medications that shrink the prostate because they block testosterone or they reduce testosterone, and that might cause other symptoms with hormone changes. And again, to talk about what's the most appropriate and specific for that patient, and again, rule out other more serious causes as well.
I'd like to echo exactly what Dr. Sather just mentioned, and in my mind, the most important thing is the bother, exactly as you already mentioned. We don't need to treat these symptoms if it doesn't bother the patient, and a lot of times patients think, well, if I get up twice at night, I have to take a medication. But if it's a routine and it doesn't have a lot of bother, and you have good restful sleep, and you're able to function well during the day, and it's not a great concern, then a lot of times no medication is sometimes the right approach.
A caller from ESCO, Dr. Novak, asking about protein in the urine, dangers of protein in the urine. Anybody can bounce in on this one as well, too.
Yeah, proteinuria is the medical term. It's typically a concern about renal damage. It's probably something that Dr. Sather sees more often than I do.
Yeah, he basically, that's the biggest concern is there damage to the kidneys. Like diabetes can cause kidney damage, high blood pressure can cause kidney damage, and lots of other certain inflammatory conditions might cause that. So if we're just seeing protein and nothing else, that might, we might look for, okay, what's causing this? We might do other follow-up tests, or even consider referral to a nephrologist if we're considered about a severe inflammatory condition causing it. But in conditions like diabetes, if it's a mild, little bit of protein, we might treat with certain medications to help protect the kidneys from any further damage. Of course, the best way to keep that from happening is if you have diabetes, get it controlled. So blood in the urine, though, might be something else that should be discussed. So.
Yeah, absolutely, because that's actually the next question, so that would be good. Maybe Dr. Johnson, you want to take that? If a patient comes in with a complaint of hematuria or blood in the urine.
Sure. That's something that we see in clinic fairly frequently. And there's kind of two broad categories for blood in the urine. Blood that you can see with your own eyes, in other words, you urinate in the morning and the urine looks red, or blood that is found under the microscope and you may not even be aware that it's there. that's called microscopic hematuria. If it's the latter, or the microscopic hematuria, there are some criteria. In other words, there have to be a certain number of red blood cells that would then initiate a workup or a urologist or another doctor to look for a cause for the blood in the urine. The actual cause of the blood in the urine can be something quite benign, and in fact, when it's microscopic hematuria, as much as 20 to 30% of the time we never find a cause, or it can be something that's more concerning. Common things that cause blood in the urine are infection, stones, either in the kidneys or the ureters, and less commonly in the bladder, or a malignancy. And that's obviously the scariest of the three that I just mentioned. But our workup is usually geared at making sure that we don't miss something like a malignancy, and if we do find something like a stone, to determine if it's something that needs to be treated. Often an infection, especially in elderly people, will cause gross hematuria, or blood that you can see with your own eyes. And in those situations, it's usually best to treat the infection first and then only go forward with further workup if the blood in the urine continues. Workup is kind of involved and often invasive. Usually imaging that includes the kidneys, the ureters, which are the tubes that drain the kidneys into the bladder, and the bladder. And then often in the office, we'll perform what's called a cystoscopy, which is a look into the bladder with a little scope. Even our advanced imaging, as good as it is, doesn't do a good job of showing the lining of the bladder. And so the only way to really evaluate that is to get a real look at it. And you can do that with a cystoscope in the office. And then from that point, once the workup is done, obviously treatment is predicated on whatever you find.
What if someone comes in with a stone? Dr. Novak, what would be the process of trying to get rid of that stone?
Well, the first thing would be to evaluate whether or not anything needs to be done. There are many stones that are small, maybe not causing any symptoms. In that case, often just leaving the stone alone is the best choice. If there are symptoms or the stone is of a size that is unlikely to pass, then I talk about treatment with the patient. Treatment, there are basically three main types of treatment. The first is commonly called lithotripsy, which is basically using X-ray technology to target a shock wave that's generated outside the body to break up the stone. Then we rely on the patient to pass the fragments. The second type is called, the fancy word is ureteroscopy, or in other words, taking a small little camera, a long, thin little camera, and threading it up through the bladder, through the tube connecting the bladder and the kidney, the ureter, and then into the kidney, and breaking it up with a laser. And then the nice thing about that treatment is you can actually remove by the larger fragments by pulling them out. The third treatment type is really reserved for very large stones that need to be treated with a little bit bigger equipment than the types of equipment that I just mentioned. And that's called PCNL, or percutaneous nephrolithotomy. In other words, making a small hole in the back directly into the kidney and then treating the stones in the operating room, of course, through that tract.
Excellent. That was a nice, concise, consolidated way to talk about it. Dr. Sather, talk about symptoms of bladder cancer. What would a man look for bladder cancer? Maybe hematuria, anything else that they would look at, or anything that puts them more at risk?
Well, they might be better at answering this than me. The patients that I have had that I've sent off for treatment of that have no symptoms at all. We usually pick it up on in my experience, pick it up if we do a urinalysis for other reasons. We find a little bit of blood in the urine and involve the workup that was discussed, and eventually they do that camera into the bladder called a cystoscopy, where they see the tumor, take biopsies to figure out what it is, and then figure out the best treatment, if it's surgery, chemotherapy, or other. I mean, again, I don't treat this all the time. So,
no, Dr. Sather, my experience is the same, where oftentimes it is asymptomatic or no symptoms at all, other than blood in the urine, either like Dr. Johnson has already mentioned, either blood that is microscopically seen or blood that is seen by the patient's own eyes, or maybe a spouse who wonders why the toilet's red. Occasionally you can have pelvic pain, urgency, frequency, urinary symptoms, but that's a little more rare and typically a little more advanced situations.
The risk factors, you asked about that. The number one identifiable one is cigarette smoking, and probably other tobacco use as well, but cigarettes by far and away are the biggest risk factor. There's some other ones that are less common, long-term exposure to chemicals or dyes, and certainly family history plays a role too. But cigarettes are the big one.
Yeah. Oh, thank you. Dr. Sather, let's talk about testicular abnormalities. I have a caller asking about a hydrocele, and maybe talk about what a hydrocele is for the audience and what we would potentially do. Would we refer, or what we would do with that?
Yeah, hydrocele is a fluid collection in the scrotum right around the testicle or near the testicle. There can be a few causes of that, but again, it's one of those things where it kind of depends on what the cause is and if the patient has symptoms or not, whether it needs to be treated or drained in some way. I see this a lot on newborn babies too, after delivery. That might last for a few weeks or a couple months, but typically goes away for newborns unless they have an ankle or a groin hernia down towards the testicle that might persist and need treatment eventually. But I don't see it much in older men. Just a couple of times, again, when it gets big enough and uncomfortable enough, they'll want to get a treatment and see a urologist.
Yeah, I describe it as basically an imbalance. There's fluid that's typically produced in the scrotum to keep everything lubricated, and then there's absorption of that fluid. And many times we don't know why. It could be something like an infection or an injury like trauma to the testicle, but many times we don't know why. There's an imbalance of production and absorption, and the net result is an accumulation of fluid. Most of the time, actually, we can leave those alone. You know, if the patient doesn't have any symptoms, if they're able to urinate normally, if they're able to engage in sexual intercourse normally, and it's not painful, then most of the time we can leave it alone. If it causes any of those problems, though, that's when I will typically talk to the patient about ways to treat.
Dr. Johnson, I know you do some robotic surgery. Can you describe the robotic surgeries, what you would do or use robotics for in the OR?
Sure. For urology, the most common procedure that we do is a prostatectomy, or a complete removal of the prostate and the seminal vesicles, and often lymph nodes in the pelvis as well. We also use it for kidney surgery, either removing the entire kidney or doing what's called a partial nephrectomy. The most common indication to do that would be a lesion that is probably a cancer, and laparoscopically or robotic assisted laparoscopically, you can remove just the tumor and leave the rest of the kidney intact, sew up the defect, and then the patient is left with 0.75% of a normal kidney. The other indications robotically are a procedure called a pyeloplasty. Well, this is not a cancer procedure, but if there's a narrowing of the ureter, you can actually excise the narrow portion and re-sew the ureter back to the kidney. At St. Luke's, where I work, it's been amazing to watch the growth in robotics outside of urology. The general surgery department and the gynecologists are starting to use it for more and more of their cases as well. So this is something that's not just for urology, and in fact seems to be spreading exponentially at the moment.
Well, thank you.
And you know, one thing I think I might mention for the viewing audience is there's usually some confusion about what robotics is, and it's not a robot doing the surgery. That's the definite. Laparoscopic surgery is the use of tiny little instruments that you can pass through small holes in the belly wall or wherever you're operating, and you control those with your own hands. A robot just allows you to adjust and move those instruments with more precision, with magnification, and much more skill.
Yeah,
like Dr. Johnson.
I think that's important. The actual console where the surgeon sits is in the room, but the surgeon is not at the bedside. An assistant often is, but listening to you talk about that reminded me of a story when I was a resident. I was talking to a man about a robotic prostatectomy, and his wife was with them, and she had this very worried look on her face. I could tell when we were done talking that something was on her mind, and so I asked her, what's up? And she said, do you ever lose control of the robot? And so she's got this picture of the robot, taking over the body and doing great harm. But no, that never happens.
The robot never does anything without the surgeon telling
Without the
Excellent.
surgeon controlling it, yeah. And the surgeon is in the room with the robot, and we keep it under good control.
Good, excellent. Well, Dr. Sather, and another caller from Duluth asking about prostate cancer. And so after you have been diagnosed with prostate cancer, what's the follow-up? As a family physician, do we follow them with serial blood tests, or what happens?
Well, it might be a better answer for them, but it depends on their surgery and what else they might need. Typically, they check blood tests every so often, and if there's kind of, I think, a standard protocol, like every so many months, and then after so many years, it backs off to once a year again. And usually, in my experience, after about 5 years out and everything's been stable, then they kind of say, okay, we don't need to see anymore, or and just kind of kick it back to us to, do an exam and check a blood test every year. But again, it depends on the patient and whether they've had a recurrence or not. So
It depends on the patient and the primary mode of treatment too. There's a concept called active surveillance, in which the treatment is no treatment at all, but more frequent checks of the PSA and perhaps repeat prostate biopsies. There's radiation treatment, and there's surgical treatment, and in each one of those scenarios you'd expect the PSA to do different things. And even after treatment, if there's recurrence of prostate cancer, then that protocol, or how often you check PSA and what your next intervention would be, would totally change. So it's very, like you said, it's very individual specific, and it's very much treatment specific in what the primary approach was.
Dr. Novak, just a quick question here, because we only have a few more minutes left, but a bladder infection for men, is that a very common thing that occurs? And if so, would we treat? How would we treat?
Sure. It's not a common thing for men. However, in older men, it can become more common. Whenever I see a man with a urinary tract infection, I always try to make sure that they don't have retention of urine, which is the inability to empty out the bladder. The big concern with that is, the body's best defense against fighting bladder infections and infection in general is usually flushing the fluid. Mm-hmm. And if your body's unable to flush the bladder, drain the bladder appropriately, then the infections can become much more frequent and much more severe.
Dr. Sather, any pearls for men's health that we want to leave the audience with?
We've been talking a lot like urological issues tonight, but again, what kills a lot more people than again, prostate cancer and things is high cholesterol and heart disease, diabetes. These are the things that we see a lot. So again, if you're at risk for those things or at a certain age, you want to talk to your doctor about getting screened with simple blood tests, and also tobacco use, as we discussed earlier, biggest risk for bladder cancer, but also risk for lots of other cancers: throat, lung, intestinal cancer, and stomach cancer with that as well. So again, if you're a smoker, make sure you're getting the right checks. There's some new guidelines now about screening for lung cancer even in patients of a certain age with a certain history. If they've smoked enough cigarettes for enough years, then now we're doing testing for that, when that wasn't, the data wasn't there in the last couple of years until I think about last year. So there's a lot of things we can do. But again, screening for heart disease, high blood pressure, diabetes are the three most common things that I do in my clinic. So.
To keep men healthy. Excellent. So I want to thank our panelists, Dr. Nicholas Johnson, Dr. Ryan Novak, and Dr. Erik Sather, and our medical students, Alicia Colling, Sarah Geller, and Aaron Mustinen. Please join Dr. Alan Johns next week for a program on arthritis, when his panelists will be Dr. Gail Baldwin, Dr. Anna Fernandez, and Dr. Wasim Khan. Thank you for watching, and good night.